Bill, regarding radiochemotherapy, which cases do you think should receive radiochemotherapy preoperatively?
Well, the German study has shown us quite clearly that if we're going to give radio, and probably the chemo as well, it is better given together and before the operation with a period for response. So for the most part, we apply clinical and MRI appraisal of whether the margins are threatened, and that I think is the most important thing. If the cancer appears fixed clinically, or on MRI, which is now our ultimate deciding factor, is the cancer within 1 millimeter of the mesorectal fascia anywhere, and of course if it's through the mesorectal fascia into an adjacent organ, that also would constitute a threatened or involved margin, and all of those cases I think should have preoperative long course chemoradiotherapy. Many people are giving it to all patients with involved lymph nodes, but our Mercury study has shown that really is not necessary. There are many patients with involved lymph nodes, and we've included in the Annals of Surgery shortly, there's going to be a paper from the Mercury follow-up showing that at 7 years there's a 3% local recurrence rate, where we haven't excluded from immediate surgery patients with positive lymph nodes. So we think that's one important change that should occur in practice, and that is to stop giving chemoradiotherapy to every patient who's got an involved lymph node, or even several, on MRI. So N2 disease, perhaps one should give it, but that's arguable. Involved margins, definitely. Penetrated margins, definitely. Lymph nodes in the lateral compartments outside the mesorectum, yes, chemoradiotherapy. Extramural vascular invasion seems to be, when seen on an MRI, a very bad prognostic feature. So I think on the principle of these patients will do badly, let's do the most aggressive operation and treatment combination that we can come up with. I think they also need chemoradiotherapy. But that leaves, in our experience, something like half, or maybe even more than half, of all the patients with rectal cancer, as we get them in southern Great Britain anyway, and I think many parts of Europe, in some parts you're getting many more very advanced tumours, and maybe the rules will be different. But where we practice, I think more than half of patients really can go straight to surgery after assessment by clinical MRI, CT for the Mets, and so on.
Does the location or the level of the tumor, according to the anal verge, affects this chemoradiotherapy?
Well, I think that's a very good question, because there has been a habit to say that because the results of low rectal cancer are worse than the results of mid-rectal cancer in many units, that you should give chemoradiotherapy on the principle that let's fire all the guns we've got. But actually, I think we should apply exactly those same indications, most particularly involved or threatened margins and extramural vascular invasion, or nodes outside the mesorectal envelope. So I would apply exactly the same.
What about upper rectal tumor? Which one should get chemoradiotherapy? None of them, or advanced ones?
Well, irradiation of the small bowel, of course, is a factor here. So in a way, you've got to involve, well, as in any case of getting radiotherapy, you've got to involve the clinical oncologist, the radiation oncologist as well. He has to be happy that the small intestine is not adherent to the upper rectum. He has to be sure that when he puts the patient face down, the small bowel slips away and he can irradiate safely. So that's a big question. I, in general, avoid giving radiotherapy to anybody with cancer above about 12 centimeters. But that will vary a bit according to the size of the patient and various other factors. So in general, I think somewhere around 12%, in general, I think somewhere around 12 centimeters is the cutoff point.
Right. What about, role of short course radiotherapy? Do you believe in short course radiotherapy or?
Of course, there's probably 10 to 100 times more short course radiotherapy cases, providing the background basis in statistics for giving radiotherapy at all. It's rather new, the long course radiotherapy and chemo data. So it's difficult not to believe in short course radiotherapy, and yet in the south of England and in many places the preference is for a selective approach and giving long course chemoradiotherapy and waiting for the downstaging, because the normal practice in short course radiation is to do the operation almost immediately afterwards, certainly within a week. And the Dutch even suggested it was better to do it in the first part of the week following the short course. And combining that with chemotherapy, except given a long time after, is not yet worked out, although it's being thought about in Sweden and elsewhere. Of course, there is no time for downstaging if you do the operation immediately, so that you haven't had the advantage of regression of the tumour from the margin, which is what you hope for with chemoradiotherapy. And as I've said, we believe you should not give radiation to any people who don't really need it. What are the side effects of radiation? My goodness, they are many. Let's start with the fact everybody is made infertile. And they're not always even told that. But it's really important for the younger patient to know that having this radiation may improve his outcomes, but you look at the Dutch trial. I was involved in doing more than 50 of the demonstration cases that were involved in trying to standardize TME surgery in Holland, and enjoyed very much in being involved in that, which is now a very well-known trial. I was involved in the teaching side of the Dutch trial, trying to standardize the TME surgery. And it was a beautifully run trial comparing short course radiotherapy against no short course radiotherapy to a background of attempted standardized TME surgery in mobile tumors, allegedly, though I know some of them weren't very mobile because I operated on some of them that were rather fixed. But anyway, there it was. What was perfectly managed by Kok van der Velde and others and his team was the running a prospective randomized controlled trial of radiotherapy, short course against no radiotherapy, with no complicating factor of chemotherapy, because they felt that chemotherapy made so little difference in rectal cancer. There isn't much evidence that it does make any difference. And they therefore excluded it altogether. So you have a perfect prospective randomized trial. Should I have short course radiotherapy or should I not? I know I want to have TME surgery. Okay, what's happened at 12 years is that about 5-6% of the patients have been saved from having a local recurrence because of the short course radiotherapy, but slightly more people are alive in the half of the trial that didn't have radiotherapy. So that seems to me very interesting, and if you ask Professor van der Velde, he will tell you why. Because about 5 or 6% of people died in the irradiated group of cardiovascular and other causes, and this constitutes, I think, one of the most challenging and interesting aspects of the non-surgical management of rectal cancer. Why are as many people dying of the effect of the radiotherapy? And we believe it may be due to the release of humoral substances, which I don't understand. I've heard thymidine phosphorylase mentioned, but I don't know if that's a humoral substance even. But it's irradiating the arteries probably. The same thing happened with a difference in breast cancer. They started by saying that you had more deaths from cardiovascular cause if you irradiated the left breast. Then they discovered it was just the same if you irradiated the right breast. And now we're discovering it's just the same if you irradiate the pelvis. So that's one of the big mysteries, because it seems to me if at 12 years the same number have died as you've helped, it hasn't been worth giving radiotherapy, because all of those people have got the side effects. They're all infertile. They're all going to the toilet at least twice as often. They're all twice as much at risk of having episodes of incontinence. They ultimately get there's autonomic nerve side effects are worse, and after 15 years, twice the risk of another cancer in the pelvic irradiated area. So there seem to me a very large number of reasons for not having radiotherapy, but of course you must give it to the person with the threatened margins or invaded margin, and perhaps to some of the other very bad prognosis cancers.
Thanks, Bill. This was quite good.
Well, it's all a bit impassioned, but I'm glad